Dr. Halverson, and Dr. Sledge and Waller, you can respond here too. Do you all agree that patients addicted to opioids should receive treatment based on their individual clinical needs? Dr. Halverson?
Yes, sir.
Dr. Sledge?
Absolutely.
Dr. Waller?
Yes.
How would you each advise HHS to take this principle into account when considering how to responsibly implement Secretary Burwell's recent announcement to expand the use of medication-assisted therapy? Dr. Halverson?
Since I'm not a physician, I'd like to defer to my colleagues here.
Okay. All right. Dr. Sledge?
And I think that prescribing physicians should be trained in all modalities of medication-assisted therapy as well as other options, particularly psychosocial treatment with abstinence as an option.
Dr. Waller?
So we've looked at this very closely in the area that I'm in charge of a 7-county area with patients and figuring out how to treat that 7-county area. We've been able to delineate 2 separate groups of patients, which we have good data for. Those that started very early in life and started earlier than in their adolescence, which have a different brain disease than started later in life. Those groups of patients actually separate us out a little bit as far as how treatment works. I have many patients in my clinic that are physicians, pilots, and lawyers who I don't give any medication to because generally it's not indicated, and we have wonderful outcomes without any medication-assisted treatment for those groups because of many other factors. My groups, which are 92% of my patients, which are Medicaid patients or those without insurance, I find that it is a perilous journey to try to treat them without buprenorphine, and the data backs that up with a high mortality rate associated with this group of patients specifically. And so Dr. Sledge and I are saying the same thing. It is absolutely the right treatment for the right patient at the right time, and making sure that we allow for an expansion of use of these medications that save lives in the hands of those people who are trained best to use them.
All right. You've touched on this, but expand a little bit more on how should differences in certain types of patients and treatment settings and therapeutic options be addressed?
Well, currently we have guidelines that directly do address the utilization of the medications. These are the first this is our first guidelines that look at all 3 of the FDA-approved medications, and it does speak to the behavioral and psychosocial therapies without medications within there. Generally, the medication treatment has been done in a cohort of patients that do not represent a physician or a pilot or a lawyer, which in general, we have programs within states that surround them that are different than the general programmatic treatment pathways. And so utilizing the guidelines that we have delineated with the appropriate education to back that up would be the way that I would say.
Dr. Sledge?
An overarching principle identified by the Institute of Medicine for successful treatment included patient self-determination, and I think that that H.R. 2872, the Opioid Addiction Treatment Modernization Act, brings patient self-determination back to the equation.
In your opinion, what are the most significant obstacles at the present time preventing more individuals with opioid use disorders from receiving the most effective treatments?
I think that one-size-fits-all treatment is very detrimental to addressing the opioid epidemic. I think that an assessment of each individual patient with recommendation and referral based on their individual needs is essential for successful treatment.
Any other significant obstacles, Dr. Waller?
I think the legal obstacles to be able to obtain the appropriate medications for patients if we deem it's the right medication for them, such as specifically buprenorphine for my patients. I treat all of the pregnant patients in that 7-county area, and I'm out of space. And so I have to turn people away to areas that are either less than optimal for them or try our best with what we can do. But unfortunately, that doesn't turn out very well.
Can each of you comment on the role nurse practitioners and physician assistants play in providing office-based opioid treatment?
I'm not a provider of office-based opioid treatment, so I'll defer to Dr. Waller.
Dr. Waller?
Without the utilization of my physician assistants, my office doesn't run. We have the capability to see patients in volume because we have well-trained physician assistants and nurse practitioners that work directly with board-certified people in their other specialties, whether this is a neurosurgeon or an orthopedic surgeon or an addiction specialist. And in this case, in addiction specialty, coupling my physician assistants along with behavioral therapists with my patients, it works out really well. And we have great outcomes from this. And this is a model that's been adopted in the medical home model of care and is relatively standardized throughout medicine. And so to eliminate this as a possibility for this specific disease doesn't make sense from a monetary standpoint nor a patient delivery standpoint.
Thank you. About a time, but Dr. Katz, you talked about synthetic drugs, and with the movement towards legalization of medical marijuana, is synthetic marijuana considered medical marijuana? Are the advocates trying to include that in medical marijuana?
Not that I'm aware of. No, I think we're talking about two different things.
Yes, it's completely synthetic.
Yes.
Yeah, that's what I thought. Thank you, and at this time, Chair recognizes the gentleman from Maryland, Mr. Sarbanes, filling in for Ranking Member Green.